Hi everybody, this is Professor Heather Murphy. Welcome back to NSG3037. Today we're talking diabetes, and this is meant to write alongside your diabetes PowerPoint, not replace it.
And I'm Caitlin Hope. I'm coming in with the bedside burn trauma brain here because we see a lot of undiagnosed or out of control diabetes in the ED and ICU.
Let's start with the clean type 1 versus type 2 picture, because NCLEX absolutely loves this contrast. Big idea. Type 1 is an autoimmune destruction of the beta cells in the pancreas. Those cells do not make insulin, zero, or basically zero insulin on board.
Right, so I tell new nurses type 1 equals no key. Insulin is the key that unlocks the cell so glucose can get in. No key, no entry, glucose piles up in the blood. Those clients are insulin dependent for life.
Type 2 is different. The pancreas often still makes insulin, but either it's not enough or the body's cells are resistant to it. I call it the dull key and rusty lock problem. The slides talk about inadequate production and insulin resistance. That's your phrase to remember.
And think about who gets tested on NCLEX. Type 1 tends to be younger, faster onset. You might see weight loss, rapid development of symptoms, even DKA at presentation. Type 2 is usually older, overweight, sedentary, with comorbidities like hypertension and smoking in the stem.
Speaking of symptoms, I want you to lock in the 3 Ps from your PowerPoint. Hyperglycemia manifestations: polyuria, increased urine output; polydipsia, thirst; polyphagia, increased hunger. Add in weight loss, dry mucous membranes, low blood pressure, high heart rate, maybe fruity breath and abdominal pain if they're tipping toward ketoacidosis.
Let's do our first NCLEX-style mini scenario. A client comes to the clinic with fatigue, blurry vision, polyuria, and unintentional weight loss. Which provider prescription should the nurse question? A. Fasting blood glucose. B. HbA1c. C. Encouraging exercise. Or D. Starting a high sugar supplement to address weight loss.
Use test-taking reasoning. What's unsafe? We absolutely want diagnostics. Fasting blood glucose, HbA1c, those match your slides. Exercise is good once stable. But giving high sugar supplements to someone with probable hyperglycemia is not safe. So D is the one you question.
Exactly. And you don't have to memorize every lab number for the exam, but you do need concepts. Fasting glucose that's consistently high, that supports diabetes. HbA1c high, that tells you their average over the last couple months is too high. On the slides, less than about 6% is the goal. Higher is a problem.
Now, sick day rules. NCLEX loves these. Your PowerPoint talks about triggers for hyperglycemia: illness, infections, stress. On sick days, you teach don't just stop insulin because they're not eating. They usually need at least basal insulin. Check blood glucose more frequently. Monitor urine for ketones. Drink fluids. And call the provider if sugars stay high or ketones are present.
And if you see exam answer choices like skip insulin when you're vomiting versus monitor glucose more often and call if levels are high, always think safety. Vomiting plus high blood sugar plus ketones, that client is on the DKA track. You want earlier contact with the provider, not less insulin.
Last quick NCLEX tip for this chapter. When you see type 1 in a stem with fruity breath and Kussmaul respirations, those deep, rapid breaths, that's screaming DKA, high priority. For type 2 with slow onset fatigue and blurry vision, that's more chronic hyperglycemia. Different urgency, different answer choices.
So as you review your slides, ask yourself, how would NCLEX turn this bullet point into a safety question? That mindset will help you a ton. Let's dive into the big scary stuff. DKA, HHS, hypoglycemia, and plain old hyperglycemia. This is where priority questions live.
Start with DKA. Your slides define it as a life-threatening complication where the body produces high levels of ketones because it's breaking down fat for energy. That happens when glucose can't get into cells, classic in type 1.
And remember the signs. The polysymptoms plus abdominal pain, nausea and vomiting, fruity breath, and Kussmaul respirations. Deep, rapid breathing as the body tries to blow off acid. In labs, you'd see significantly elevated glucose, ketones in blood and urine, and metabolic acidosis, but the exam usually just says blood glucose very high, ketones present, pH low.
HHS, or hyperosmolar hyperglycemic state, is more of a type 2 problem. Your slides don't detail it, but conceptually, very high blood glucose, severe dehydration, minimal or no ketones. Think older adult with type 2, infection, altered mental status, dry mucous membranes, but not the strong fruity breath and Kussmaul's you see with DKA.
Now, hypoglycemia. The slides spell out that blood glucose around 70 or less triggers the sympathetic nervous system. So you see that fight or flight pattern: headache, sweating, tachycardia, irritability, restlessness, excessive hunger, dizziness. They even give you the mnemonic, he's tired.
NCLEX loves this. You'll get a question where several diabetic clients need you. Who do you see first? Use ABCs in Maslow: airway, breathing, circulation. Also think, which condition kills fastest? Severe hypoglycemia can cause seizures, coma, death very quickly. Your slides list all those complications.
Mini scenario: 4 clients. A. Type 2 with polyuria and polydipsia. B. Type 1 with blood glucose 52, sweating and trembling. C. Type 1 with blood glucose 320, no ketones, asking about diet. D. Type 2 with neuropathy and a small foot ulcer. Who's first?
Prioritize B. That low blood sugar plus symptoms is an immediate circulation and neurological threat. That's your unstable client. The others are important, but more chronic.
And what's your first line intervention for conscious hypoglycemia? The slides give you the 15 to 15 rule. 15 grams of fast-acting carbohydrate now, recheck in 15 minutes. So juice, regular soda, glucose tablets, honey, not high-fat foods like peanut butter.
If they can't safely swallow or have decreased level of consciousness, the slides say IM or SQ glucagon. In acute care, you may also see IV dextrose. On NCLEX, if the client is unresponsive, don't choose give orange juice. That's an aspiration risk. Pick glucagon or IV dextrose.
For DKA and HHS, first-line nursing actions follow ABCs and circulation. Start with airway and breathing assessment, then circulation, IV access, fluids, monitor vital signs and mental status. Insulin will be ordered to lower glucose and stop ketone production in DKA. You're also watching potassium closely, even though your slides don't dive deep there.
And your PowerPoint emphasizes the nurse's role. Recognize cues, analyze, plan, implement, and evaluate. So for hyperglycemia, you're monitoring glucose, administering medications, teaching lifestyle changes, and preventing progression to crisis.
NCLEX strategy moment. When you see labs, don't get lost in exact numbers. Ask, is this clearly high, clearly low, or normal? High glucose plus symptoms of dehydration and altered cognition? That's a red flag. Low glucose with sweating and confusion? Bigger red flag. Always go back to ABCs and which situation is most immediately life-threatening.
And keep Maslow in the back of your mind. Physiological needs, airway, breathing, circulation, glucose to the brain, come before teaching, before long-term diet changes, before psychosocial concerns. That's how you sort answer choices. Now let's pull it together with meds and teaching, because that's where a lot of your exam questions will land.
On the insulin side, your slides give a nice table. You don't have to memorize every minute, but you do need the pattern. Rapid acting like Lispro hits fast and peaks fast, so risk for hypoglycemia is highest around that peak. Short-acting regular, intermediate NPH, and long-acting glargine have progressively longer durations.
And the slide on insulin safety is big for NCLEX. Correct strength, correct syringe size, knowing which insulins can be mixed, and understanding action, peak, and duration. Also storage. Room temperature insulin is okay for about a month, and avoid extreme heat or cold.
Insulin pumps are in there too. Continuous basal infusion with boluses at meals based on intake, and change the insertion site every 2 to 3 days. If NCLEX gives you a pump client with nausea, vomiting, and high blood glucose, think, is the site due to be changed? Is the pump delivering correctly?
For oral meds, your slides highlight metformin as a first-line treatment in type 2. It lowers the amount of glucose the liver makes and decreases absorption from food. It's contraindicated in severe kidney problems and metabolic acidosis and can cause GI side effects like bloating and abdominal pain.
Quick exam pointer. Even though your slides don't spell it out, in practice, metformin is often held around procedures with contrast because of kidney risk. So if you see an NCLEX stem about a client on metformin going for contrast studies, be suspicious of answer choices that ignore kidney function.
The hypoglycemia risk meds list is also on your slides. Insulin, sulfonylureas, and even some other medications can contribute. And beta blockers can mask hypoglycemia signs like tachycardia, which is a really high yield safety point.
Let's hit teaching. The slides repeat this theme. Monitor blood glucose, know your targets, and recognize manifestations of high and low blood sugar. They also stress diet and exercise, preventing infection, and daily foot care and inspection, especially in type 1 and type 2 with neuropathy.
We also teach storage and disposal of supplies, wearing a medical ID bracelet, and monitoring urine for ketones when at risk. And remember, current guidelines like the ADA standards of care focus on person-centered glucose targets and using tools like continuous glucose monitors and pumps to prevent complications. You don't need all the gadget details for NCLEX, but know that technology is part of modern management.
One more NCLEX walkthrough. The question says, which statement by a client with type 2 diabetes taking metformin indicates a need for further teaching? Option A, I'll take this medication with meals. B, I'll report severe abdominal pain to my provider. C, if I feel shaky and sweaty, I'll check my blood sugar. D, if my sugar is low, I'll lie down and skip eating until it passes.
Use your safety lens. A, B, and C are solid. D is dangerous. Lying down and not treating hypoglycemia risks seizures, coma, and all those complications from your slides. So D is the incorrect statement, and that's your answer.
Another pattern to watch. Distractors that sound caring but are unsafe, like, I'll drive myself to the hospital if I'm dizzy and confused from low blood sugar. No, safety first. You'd teach them to treat the low blood sugar immediately or call for help.
As you study, combine your diabetes PowerPoint, this conversation, and lots of NCLEX-style questions. Focus on type 1 versus type 2, the 3 Ps, recognizing hypo versus hyperglycemia, and first actions for DKA-like symptoms. Don't forget to review metabolic syndrome and the 5 criteria that are involved. Remember, a patient needs to meet 3 out of 5 of those conditions to be diagnosed as having metabolic syndrome.
And always ask, what keeps this client safest in the next 5 minutes? That question alone helps you pick better answers.
You all are absolutely capable of mastering this. Keep reviewing, keep practicing those scenarios, and bring your questions back to class.
All right, that's it for this episode. Thanks for hanging out with us.
Take care, everyone.
Bye!